Sir, we are live now. I request your
Yeah,
permission to start with the session, sir. Thank you, sir. Thank you. Hari Home, everyone.
yeah,
A warm welcome to
yeah,
the
you can start.
21st session of Mind Anatomy, a lecture series for the first year BMS students. The exclusive sessions will be taken up by the eminent speakers of anatomy across the country for a period of 27 days, which started from 23rd of June and will be running up to 17th of July. Before starting the session, let me introduce you to Jignasa. Jignasa is a pan-India platform of Ayush fraternity led by the student community of Bharata and was initiated by ABVP in the year 1998. Its motto is Learn Ayush to Practice Ayush. It involves empowering Ayush students from campus to community, bridging the gap between Ayush students and policymakers as well as administrative authorities, connecting every aspect of Ayush, including academicians, practitioners, scientists, industrialists, and hospitals all under one umbrella. Think globally, act locally. In last 2 decades, our efforts were to strengthen the Ayush education system and boost confidence among Ayush students. Jignasa initiated various programs in different parts of the country from the grassroots to international platforms through discussions, study circles, seminars, workshops, and conferences. Let me list a few initiatives undertaken by Jignasa. Starting with study circles, lecture series on specific topics, free medical camps, social health status surveys, hands-on training workshops, conferences to explore and learn unique aspects of Ayurveda, interaction with eminent Vaidyas and academicians, brainstorming session with Ayurveda stalwarts, policy makers, and key stakeholders of Ayurveda systems. National Arogya Expo and International Conference, national level seminars, medicinal plant visits, pharmaceutical visits, agitations for the demands of high students community, private internship program for interested students to learn with acharyas, interaction with traditional healers and visits to explore regional flora, online mock test, social awareness campaign on various issues, campaigns for the promotions of various concepts of Ayush systems for social welfare like Swarna Bindu Prashana Camp, Ashwashatattari Yoga, Group Story Namaskar and other yoga competitions. Free healthcare assistance to people through local governing bodies during natural calamities and accidents were also provided by Jignasa organization. In our yesterday session, more than 800 students joined for the live session and asked their queries regarding the subject and examination. And so far, we are proud to say we have received as much as 14,000 views on our channel for sessions of higher anatomy. We hope to reach as many students as possible who can take maximum benefit out of this. Vidya Navanarasya Rupamadikam Prachanna Guptam Dhanam. We have seen the inability of a common student to afford huge amounts on commercial study platforms despite their jignasa, the burning desire to learn. Jignasa is here to give a helping hand. Learn anatomy with experts, and all we need is your immense interest to learn. Today, we have we have Dr. Praveen Shagada K, BMS MD, Reader and HOD, Rachana Sharira, Government Ayurveda Medical College and Hospital, Kottar, Nagarkoil. Sir completed his BMS from JSS Ayurveda Medical College and Hospital in year 2004 and MD Rachana Sharira from NKJ Ayurveda Medical College, Bidar. Sir is been a lecturer in MNR Ayurveda Medical College and Hospital, Sangareddy, assistant professor in JSS Ayurveda Medical College and Hospital, Mysore, reader in JSS Ayurveda Medical College and Hospital, Mysore, reader Government Ayurveda Medical College and Hospital, Kottar, Nagarkoil, worked as assistant NSS coordinator at JSS Ayurveda Medical College and Hospital, Mysore, organized dead body donation public awareness program and poster competition, undertaken various Swachh Bharat Abhiyana programs as a coordinator, presented papers in national, international seminars, published articles in reputed journals. Sir has a total teaching experience of 14 years and delivered guest speech on Garbhasya Parivriddhi at webinar Jnana Sharira in 2020 in SBS Ayurveda Medical College and Hospital, Belgavi, and 2021 at Sri Babu Singha Jaya Singh Ayurveda Medical College and Hospital, Farrakbad, UP. Sir I was also delivered lecture on Linga Vinishya webinar at Ayurveda Mahavidyalaya Hubballi 2020. Sir, we welcome you to the session, sir. We are happy to have you on the session today, and everyone who is watching this, hope you find it this helpful. Sir, now I request you to carry forward with the session.
I extend great pleasure for your warm welcome, and I'm very much thankful for considering my convenient time for the session. So herewith, I will begin with my session. So the respiratory system is a very vast area where we are dealing with, and that we are going to understand in these headings. First, we are going to see about the introduction in a brief, and then we will be seeing about its parts. Then, in brief, about the development, and then description of individual parts of the respiratory system in detail, And before that, once again, we will be reviewing the development of the respiratory system. And afterwards, a few lines regarding what we talked already, and then we'll be concluding the session. So in this way, we'll be discussing the things. So, first of all, uh, we are well aware of the um, different level of organization, so molecular and cellular level of organization of a human body, cell, tissue, system. So, to work in a coordinating way, the group of the cells, tissues, organs which come together to perform a specific function. So that is called as a system. Here we are understanding the respiratory system where all these organs are coming together to function to deliver the function of the respiration. When we see, it is the respiratory system is a very vast in its spread. We see it extends from nose, nasal cavity, mouth, and even the sinuses, pharynx, larynx, trachea, bronchial tube, lungs, tonsils, throat. So all this, even the ribs and diaphragm also to be considered as a part of the respiratory system. So it is having the wide contribution from even from the different systems. So generally, when we talk about the respiratory system, just first comes to our mind is trachea and the lungs only. So further, when we start thinking of it still more, then we will be getting the complete picture of the respiratory system. For the systematic understanding of the respiratory system, we'll be studying the respiratory system in the. We'll be dividing this respiratory tract. Tract is different, and the system is different. The tract is the one which is divided into upper respiratory tract as well as the lower respiratory tract. The upper respiratory tract consists of the nose, mouth, sinuses, pharynx, larynx, and then finally we consider the lower respiratory tract like trachea, bronchial tube, and lungs. These are the lower respiratory tract. So generally, we'll be concentrating only on this much things, whereas other things will be not concentrating much during our studies on the. In Definitely, we'll be studying all the parts and parts of this. All the parts we'll be studying, but we'll be studying in different headings. Like when we are studying about the sensory organs, we'll be studying about the nasal cavity or nose, and then with the myology, we'll be studying about the diaphragm, and with the osteology, we'll be studying about the ribs and all. So we'll be just seeing much important things over here, how those things are being considered. So when we see the members or the parts of the upper respiratory tract, up to the larynx is the upper respiratory tract, and next to the larynx is the lower respiratory tract. When we see this structure in a brief, the nose and nasal cavity is the best entrance for outside the air into your respiratory system. The hairs that line the inside wall of the wall are the part of the air cleansing. So nose and nasal cavity is lined with the hairs, so which will be holding back the macromolecules which are in the inspired air. So here what we are finding is it is cleansing the air what we are inhaling. So the next is the sinuses, the hollow spaces in the bones of our head. Small openings connect them to the nasal cavity. These sinuses help to regulate the temperature and humidity of the air breath, what we breathe in, as well as lighten the bone structure of the head and give tone to our voice. So these sinuses, mainly while understanding about the classification of the bones, we'll be understanding the pneumatic bones, the bones where the air spaces are present. Those bones are called as the sinuses. So the main motive of these pneumatic bones is to provide the economical expansion where the larger surface area is required for the attachment of the muscles. This only will happen when we are discussing all the things together. So here let us restrict to the sinuses, which part is related to the respiratory system rather than going to the muscular system. So here the sinuses, the main what the contribution of sinuses to the respiratory system, it will be regulating the temperature and humidity of the air what we breathe. So if we the alveoli are very delicate structures where the gases exchange is taking place. So if the same air whatever we are breathing in and it is going to the alveoli, then it will be what damaged. So for that, or it will be infected, or it may be prone for many pathological things. So that air has to be air conditioned, means the certain with the temperature, with the humidity, it has to reach the alveolar spaces, and then only the gases exchange will be taking in a healthy manner. So the sinuses will be helping to conditioning the air, whatever the cilia is present in the nose, as well as these sinuses will be cleansing the air and it will be conditioning the air for further process of respiration. So then the mouth air also can enter through the mouth or oral cavity, especially if you have a mouth breathing habit of your nasal passages may be temporarily blocked. Whenever the nasal cavities are been blocked, then in that situation we'll be taking the air through the mouth. So then, for immediately then we have the two what gods in the oropharyngeal isthmus. They are the tonsils. They are the important part of the immune system. They will be fighting with the what do you say, the infecting thing. They will be part of the immune system, and they will reduce minimize the rate of the infection, spreading infections from the oral cavity toward the further respiratory system and all. Throat, it collects the incoming air, whatever the air is coming from the nose and the mouth, that will be coming to the throat. There present that is the pharynx. So nasopharynx, oropharynx, laryngopharynx. So from there, that air will be passing down via larynx to the trachea. The larynx is nothing but the inlet of the lower respiratory tract, and air breathed in creates the sounds. So windpipe, the passage leading from larynx to the lungs is the windpipe or the trachea, and the trachea further divides into bronchial tubes, bronchi, and that goes to the lungs and subdivided into bronchioles. The bronchioles are the smallest section of the bronchi, are called as the bronchioles, and at the end of which are the alveoli, or the plural of the alveolus. Alveoli is the plural and alveolus is the singular. So the next, what is the alveolus? Here we can see the alveoli. These are the alveoli sacs and all. So very small air sacs that are the destination of that we breathe in. So here the capillary vessels embedded in the walls of the alveoli, and blood processed through the capillaries and brought to them by the pulmonary artery and taken away by the pulmonary vein. And in the capillaries, the blood moves carbon dioxide into the alveoli and takes up and oxygen from the air in the alveoli. So here in the alveoli, what happens? Gaseous exchange takes place. To the alveoli, the deoxygenated blood is brought by the pulmonary artery and its branches, and oxygenated blood is taken away from the alveoli by the pulmonary vein to the heart. So this is about where this air is coming directly in contact with that. So further, when we see that uh, these alveoli, these respiratory bronchioles, segmental bronchioles, and all, they will be part of the lungs, and this lungs is covered in the uh, sac, that is the membranes, that is are called as the pleura. This pleura will be separating the lungs from the chest wall. So like this, and the bronchial tubes are lined by the cilia that we have like motion. Okay, that we'll discuss while discussing completely. The here we need to say that we want to mean to say that the pleura is nothing but the covering of the lungs, so which have the major role to play of both for the respiration as well as the protective. So whenever there is a collection of the fluid or air, definitely the respiratory system will be affected. The similarly the lungs is the main center of the main organ of the respiration, which is having the right lung and the left lung. Further, the divisions details we'll see in the further the slides. The ribs and diaphragm are nothing but the supporting structures for the process of respiration. They move small amount and help lungs to expand and contract. Just a small amount of the movement of the ribs will be helping the lungs to expand and contract. Whereas diaphragm is also is the strong wall of the muscle, and that separates the chest cavity and from the abdominal cavity by moving forward, and it creates the suction to draw in air and expand the lungs. So here we have just understood the principal structures and their functions contributing for the function of the respiration. So in brief, we'll see the how this respiratory system is being developed, because in detail is time consuming, so we'll be just seeing how this respiratory system is developed. The respiratory system is derived from the primitive gut tube, the precursor to the gastrointestinal tract. Gut tube is an endodermal structure which forms when embryo undergoes a lateral folding during the early embryonic period. Approximately at the fourth week, development of the outpocketing appears in the proximal part of the primitive gut, and this is known as a respiratory diverticulum. So, in short, to say that the respiratory system is developed from the outpouching of the gastrointestinal tract. Initially, this respiratory diverticulum is continuous with the foregut, but this is not functionally suitable. So initially, whatever this diverticulum, that will be continuing with the foregut, but as functional unsuitability, there develops the tracheoesophageal septum, which rectifies these two structures compatible with the life. So what it means is the respiratory system is continuing. If it is continuing with the foregut, if the food is entering the respiratory system, then it will be completely blocking the respiratory system. So there needs a food path and separation of the food path and the air path. For that, there develops the tracheoesophageal septum, and by that the danger to the life will be avoided. If this tracheoesophageal septum is not existing, that causes the difficulty in breathing by continue by entrance of the food into the what do you say respiratory system. That this diverticulum further, see that this is the beginning of fourth week. This is the diverticulum, and here it has been separated by the tracheoesophageal septum, and further this divides into the principal bronchus, and then buds are seen, and this bifurcation of the then bronchial buds, and then bronchial buds develops, then the lobes are developed. So in short, about the components of the respiratory system, and how, in short, we have seen how the thing has been developed. So how the respiratory system is developed. The respiratory system is nothing but the outpocketing or diverticulum of the gut tube only. There develops the tracheoesophageal septum. By that, this complete the GI tract and respiratory tract has been separated. So sometimes there is a connection, tracheoesophageal fistula, or may be existing due to incomplete development of this tracheoesophageal septum, that we'll see in further. So now the first thing what we are going to understand is the each structure one by one we are going to understand. So here the nose, as already I told, we are almost times this complete structure of the nose we are understanding under the sensory organ. But when we see the upper one third of the nasal cavity is only with the olfactory mucosa, whereas rest of it is of the respiratory function. And when we see that the nasal cavity is lined by respiratory mucosa, and respiratory mucosa is highly vascular and warms the inspired air. So whatever the lower two-third of the nasal cavity, that is lined with the highly vascular, and it is respiratory mucosa and is by the inspired air. And here presence of numerous serous and mucous glands. So because of this serous and mucous glands, whatever the larger particles present in the air, they will be trapped in that mucus, and the air is being warmed and conditioned and cleansed, and then it will be sent to the delicate organ. So this is how what function happening in the nasal cavity. So in the upper one third of the nasal cavity is roof is formed by the cribriform plate and medial and lateral walls up to the level of superior concha, and it is thin and less vascular than the respiratory mucosa. It contains the respirators called as olfactory receptors called as olfactory cells. So in the nasal cavity, upper one third is covered by the olfactory mucosa, lower two third is covered by the respiratory mucosa. Respiratory mucosa is more vascular and studded with the serous gland and mucous gland, which will be helping the trapping the larger molecules present in the air and air conditioning for to further process of the respiration to send the air. So now when we see the structure of the nose, so we have dorsum, tip, ala, and nostril and columella. So these are all the external surfaces, external structures or surface landmarks of the nose. So when we see that the skeleton of the nose, the bones are the nasal bones, mainly the nasal bones, which form the bridge of the nose, and front and that nasal bones articulate with the frontal process of the maxilla and cartilage, superior and inferior nasal cartilages, septal cartilages, and small alar cartilages, and skin over the external nose is supplied by the external line infratrochlear infraorbital nerve. So here what the take home is, all the this is whatever the prominence of the nose is called as the dorsum and tip, and either side is the ala, nostril and columel, and the bones are formed by the nasal bones, frontal process of the maxilla, as well as the septal cartilage and small alar cartilages. So these are the structure of the external nose. When we see the internal nose, the or nasal cavity, the nasal cavity extends from external nares or the nostrils to the posterior nasal aperture, to the posterior. So this is the external nares, and up to the posterior nasal aperture, up to here, this is the nasal cavity. So the nasal cavity is having this is floor, roof, and whatever we are seeing, this is lateral wall. As it is sagittal section, medial wall has been removed. So it is having the medial wall, lateral wall, roof, and floor. So these are the boundaries of the nasal cavity. So if we understand the things and we go, then it will be very easy. Otherwise, it will be just mugging up. So now you can see here. So this is the floor, the roof, and whatever you are seeing, this is the lateral wall, and the medial wall. As it is a sagittal section, medial wall is not seen. So then there are various measurements are being given that you can go through it. Uh, so that the roof is sloping anteriorly as well as posteriorly. It slopes downwards both in front and behind. Middle is a horizontal part. Middle is a horizontal part formed by the cribriform plate. By cribriform plate. Through this only the olfactory nerves will be going to the cranial cavity. Then the posterior slope. This is the posterior slope formed by the sphenoid bone. The floor is about 5 centimeter long and 1.5 centimeter wide and is formed by the palatine. See that already while discussing about the palate and all, we will be knowing that it has been formed by the horizontal plate of the palatine bone and palatine process of the maxilla. So this will be forming the roof of the oral cavity and floor of the nasal cavity. So when we see that, it is concave from side to side and slightly higher anteriorly than the posteriorly. So anterior, see that here it is higher and it is smaller in the posterior side. So now when we have understood the nasal cavity, its boundaries and this, so just about its what do you say, clinical anatomy. So this nasal, mainly the common cold, then the paranasal sinuses may get infected from the nose. As we know that all the sinuses will be opening into the nose. So if we get the common cold and if it is not treated for longer time, then it will be infecting the other sinuses. The relations of the nose with the anterocranial fossa through the cribriform plate and lacrimal apparatus through the nasolacrimal duct important in the spread of the infection. So the like this, the infection can be spread even to the cranial fossa as well as it will be spread to the lacrimal apparatus. Then one more the clinical thing, whenever this cribriform plate has been getting fractured or it has been teared off, so then the CSF may drip through the nasal cavity and it is called as CSF rhinorrhea. So what are all the clinical aspects we need to understand is the common cold, maxillary sinusitis, and the spread of the infection, and as well as the CSF rhinorrhea. We have to understand these things. So here already we have understood here it is having the medial wall, lateral wall, floor, floor and roof. So you see here, this is nothing but the medial wall of the nasal cavity, that is called as the septum. The septum is a osteocartilaginous partition between the two halves of the nasal cavity. So it is having the vomer bone. It is having the vomer bone and perpendicular plate of the ethmoid and septal cartilage and septal process of the inferior nasal cartilage. All these together will be forming the septum, which separates right and left nasal cavities from each other. And when we see that it is having the superior border and then inferior border and then anterior border and then posterior border. So inferior, superior, anterior, posterior, and it will be having two surfaces, right and left surface. Two surfaces, right and left surfaces. So this is about the nasal septum. Here what you have to understand is what are all the Bony parts, what are all the cartilaginous part? Bony part, perpendicular plate of ethmoid, vomer bone, cartilage, septal cartilage, and septal process of the inferior nasal cartilage. These are the parts of the nasal septum. So this you have to understand with the medial wall of the nasal cavity. So now when we see that arterial supply of the nasal cavity, we can see that so antero superior part by the anterior ethmoidal and anterior superior part, anterior and posterior ethmoidal both, and posterior superior part mainly by the sphenopalatine artery, and posterior inferior part by the greater palatine artery, and anterior inferior part by the uh, sphenopalatine, anterior inferior part from the labial artery, superior labial artery. This is superior labial artery. So this is the blood supply to the nasal cavity. So when we see the venous drainage, the veins from the form the plexus more marked in the lower part here, whatever shown here, the vessels coming here, the veins that is at this level, whatever the veins are coming, marked in the lower part of the septum, and that is called a little area. Here comes the facial vein, sphenopalatine vein, and pterygoid venous plexus. Pterygoid venous plexus. All these things are forming the, what do you say, the little's area. So then when we see about the nerve supply, general sensory is by the trigeminal nerve are distributed to the whole septum. So antero superior part supplied by the anterior ethmoidal nerve, anterior inferior supplied by the anterior superior alveolar nerve, and posterior superior part is by the medial and posterior nasal branches, and posterior inferior by the nasopalatine nerve. So this whatever the from the pterygopalatine ganglion, both, whatever the posterior part supplied by the pterygopalatine ganglion. Then when we see the special sensory, already we have discussed that, that is nothing but the olfactory nerve, lymphatic drainage, submandibular as well as retropharyngeal nerve and all. So this is about the nasal cavity. In the nasal cavity, what we have understood? Roof, floor, medial wall, lateral wall. Now we have just understood the medial wall. We have to see about the lateral wall. So generally, the pathological deviation of nasal septum is often responsible. So see, you can see here, this deviated nasal septum is more often responsible for the frequent allergic rhinitis, sinusitis and all. So sphenopalatine artery is an artery of epistaxis. Little area on the septum is common site for the bleeding from the epistaxis. So mainly from the sphenopalatine artery, that will be the bleeding that is present. Whatever we have seen shown here, the little's area here apart from the sphenopalatine artery, there is a contribution of other arteries also, like superior labial artery as a posterior ethmoidal artery is coming, but mainly the sphenopalatine artery is responsible for the bleeding. When we see about the lateral wall, we can see mainly it is having the three concave, superior concave, middle concave, as well as the inferior concave. Lateral wall is irregular because of presence of this concave. So between this concave, and as this is irregular, this will be increasing the surface area for the inspired air for conditioning it. So this lateral wall of the nose will be separating it from the this is the nasal cavity. So this is the medial wall and this is the lateral wall. This lateral wall will be separating from the orbit as well as the maxillary sinus as well as the lacrimal apparatus. So lateral wall will be separating orbit as well as maxillary sinus as well as from the the nasolacrimal duct. So now further, when we see this is the three concaves we are seeing. Lateral wall can be divided into three parts. A small depressed area in front of the depressed area, anterior part is called as, this is called as the vestibule, and it is lined by the hairs. They are called as the vibrissae. The middle part here, this is the atrium, and the posterior part that contains the concave. So this complete nasal cavity is divided into vestibule, atria. This is the anterior part, this is the middle part, and this is the posterior part, which contains the concave, and spaces separating this concave, superior concave, middle concave, and inferior concave is separated by the superior, and middle is separated by superior meatus, middle and inferior is separated by So skeleton of the lateral wall is now, in brief, we'll see the skeleton of the lateral wall. You can see here. The skeleton of the lateral wall is partly bony and partly cartilaginous, made up of the soft tissues. So mainly the nasal bone and frontal process of the maxilla, and then lacrimal bone, and then labyrinth of the ethmoid bone, and inferior see here, what all things: nasal bone, frontal process of the maxilla, labyrinth of the ethmoid bone, as well as inferior nasal concave made up of the spongy bone only. So perpendicular plate of palatine bone together with the orbital bones. So all these things, and medial pterygoid plate. The cartilaginous part is formed by the superior nasal cartilage and inferior nasal cartilage, and 3 to 4 small cartilages of the ala. So all these things are forming the the lateral wall of the nose. So labyrinth of ethmoid, nasal concave, and perpendicular plate of the palatine bone together with the orbital and sphenoidal process, and medial pterygoid plate. All these things, and the cartilaginous part is superior nasal cartilage as well as the inferior nasal cartilage, and 3 to 4 small cartilages of the ala. This is forming the lateral wall of the nose. So mainly here in the lateral wall, when it concerned with the process of respiration, we have to concentrate on the lateral wall and the openings within it, whatever the openings we are seeing here. The concave and meatus, already we have understood. These are the three concaves and these are the meatuses. So when we see the inferior meatus is lying below the inferior concave, and it is the largest meatus, and nasolacrimal duct opens it at the junction of anterior 1/3 and the posterior 2/3. So see, you can see here, here is the opening of the nasolacrimal duct in the the inferior meatus. So whereas in the middle meatus, this is very much important. Middle meatus is very much important from the part of respiration, because all the paranasal air sinuses are been opening into the middle, and only one will be opening into the superior meatus. In the middle meatus, you can see that ethmoidal bulla underlying the bulla here. The ethmoidal sinus will be opening at the upper margin of this bulla, and hiatus semilunaris, that is deep semicircular sulcus below the bulla, and infundibulum is a short and anterior end of the hiatus. The opening of the frontal air sinus seen is anterior to the semilunar hiatus. Opening of the frontal air sinus. So here you can see the frontal air sinus, and then we are seeing here is the maxillary air sinus just posterior to the the frontal air sinus, and opening of the anterior ethmoidal ear sinus is present behind the frontal ear sinus. So we can see here frontal ear sinus, ethmoidal ear sinus, as well as maxillary ear sinus here. And the opening of the maxillary ear sinus is located in the posterior part of the hiatus seminaris. So this is called as the hiatus seminaris, and is the anterior part of hiatus seminaris, and this is the posterior part of the hiatus seminaris. The superior meatus lies below the superior concha, and in this opens is the sphenoethmoidal races. So triangular fossa above the superior concha, it is the opening of the sphenoidal ear sinus. Just in front of the middle meatus, this is the middle meatus, and the middle meatus is the vestibule limited above the agar nasi. So again, same, the arterial supplies, already we have discussed this while discussing after discussing the medial wall. And next, the nerve supply of the lateral wall, anterior superior quadrant, anterior superior quadrant, mainly by the anterior ethmoidal nerve. This is the anterior ethmoidal nerve, which is nothing but the branch of ophthalmic. Anterior inferior quadrant, mainly by the anterior superior alveolar, which is nothing but the branch of the maxillary nerve. Anterior superior quadrant, there is lateral posterior superior nasal branches, which are nothing but the branch of pterygopalatine. Anterior inferior, mainly by the anterior palatine branches. So these are all by the pterygopalatine ganglion. So here, special sensory olfactory nerve is distributed to the upper part. So same thing, whatever we have discussed, same thing is we have to understand here. So now what happens here is hypertrophy of the mucosa over the inferior nasal concha is sneezing, nasal blockage, excessive discharge from the nose. So hypertrophy of the nasal mucosa causes these symptoms. So this we concluded about the, what do you say about the nasal cavity. Next is this will generally will be covering in the nose, and everyone will be completely aware of these structures and all. The most remote part of the nasal respiratory system will left in the covering the syllabus and all is the paranasal sinuses. Mainly the paranasal sinuses are present within the some bones around the nasal cavity. The bones which are present around the nasal cavity, their present is the paranasal ear sinuses. So mainly they are frontal, here maxillary, and sphenoidal and ethmoidal. So this is the maxillary, frontal, and largest one is the maxillary, then is the sphenoidal, then is the frontal, and ethmoidal are many in number. For that we can see here. So all these sinuses open into the nasal cavity. If the infections of nasal cavity has not been treated, then these sinuses may get infected and causes the sinusitis. So all of them open nasal cavity through, and sinuses make the skull lighter, warm, and humidify the inspired air. After the this will be helping in the humidifying and warming the air, and it adds resonance to the voice. Now this we understood what is the utility of the sinus. It is just warming the air and lighting the, it reduces the weight of the skull. And when we see that the development of sinus, it is rudimentary or even absent at the birth. These sinuses are rudimentary or even absent at the birth. So reason is at the respiratory functions is not been begin. So then they enlarge rapidly during 6 to 7 years. That is the time of the eruption of the permanent teeth, and then after puberty. So they are rudimentary at the time of birth, and they enlarge by 6 to 7 years. From birth to adult life, growth of the sinuses due to enlargement of the bones. So from birth to adult life, due to the enlargement of the bones, sinuses will be developing. In a old age, in a old age, it is due to the resorption of the surrounding and cancellation. So we know that the bones will be resorpting at the old age. So at the birth, the sinuses is rudimentary. From birth to the adult, the bones are been enlarging. Along with that, the sinuses will also get enlarged, and still they become larger in the old age due to the bone resorption. So this is about the general thing about the paranasal sinuses. Frontal, maxillary, sphenoidal, ethmoidal. They are named on behalf of the bones where they are been present. Now just we are seeing where by seeing diagram we can make out its location, but still we'll understand where these are present. Just above frontal air sinus is present just above the superciliary arch. It extends upwards above the medial end of the eyebrow. It opens into the medial meatus, anterior end of the hiatus semilunaris. You can see here in the anterior end of the hiatus semilunaris it will be opening. And right and left sinuses are usually unequal in size. Rarely one or both may be absent. Their average height, width, and anteroposterior depth is 2.5 centimeter. So it is present in the frontal bone. It is opening in the anterior part of the hiatus semilunaris. And one more thing, this right and left are unequal. Their average width of the anteroposterior depth is 2.5 centimeter. The sinuses are better developed in males than in females. So one thing, they are rudimentary at the birth and they are well developed by 7 to 8 years. And again, the sinuses may enlarge during the old age by the bone resorption. This is arterial supply, superior orbital artery, supraorbital and superior ophthalmic veins, and submandibular nodes and supraorbital nerve. So this is about the frontal sinus. So just I will highlight the few things because the time restriction. So maxillary sinus is pyramidal in shape. So here what we need to understand under each sinus, what shape of the sinus, which bone it has been located, and what is its measurement. For all the sinuses, we have to understand that only. Here it is a pyramidal shape. Base is directed medially towards the lateral wall of the nose. Apex is directed towards the zygomatic process. And it opens in the middle meatus of the nose. So maxillary sinus is all the sinuses are opening in middle except the sphenoidal. That is just behind the frontal sinus. Opening is the maxillary sinus. After ethmoidal, frontal and ethmoidal, opening is the maxillary sinus. So hiatus semilunaris, lower part of the hiatus semilunaris, it is isolated from the maxilla and it is 4 mm. So it is 2.5 centimeter. It is the opening is reduced to 3 to 4 mm as it is overlapped by the following. So the opening is reduced by the overlapping of these structures, that uncinate process of the ethmoid bone, descending part of the lacrimal bone, from below inferior nasal concha, from behind perpendicular plate of pallidum bone and all. So here you just understand that where it is present, what is the shape, and where it is opening. That only you have to understand here. The again next is the size is variable. So this details much not required. The sphenoidal sinus, the right and left sphenoidal sinuses lie within the sphenoid bone. They are separated by the septum. The two sinuses are unequal in size. Each sphenoidal recess corresponds to half of the nasal cavity. So here, this is the sphenoidal air sinus. These both are opposite with each other. So see that sphenoidal is present in the posterior aspect. So here, this is the sphenoidal air sinus, and it is opening into the superior meatus. It's opening superior meatus it is opening. Next, so ethmoidal sinuses. So these are the ethmoidal sinuses. So this ethmoidal sinus are anterior ethmoidal sinus, middle ethmoidal sinus, and so see that anterior ethmoidal sinus, middle ethmoidal sinus, and posterior ethmoidal sinus. And all these ethmoidal sinuses are opening. So anterior ethmoidal sinus is opening just behind the frontal sinus, and then middle ethmoidal sinus 1 to 7 open into the middle. It is supplied by the anterior ethmoidal nerve and all. Posterior ethmoidal 1 to 7 that opens in the superior meatus. The posterior 1 to 7 superior meatus of the nose. It is supplied by the ethmoidal nerve and vessels. So here you can see here this is the anterior ethmoidal sinus. This is the middle ethmoidal sinus, anterior ethmoidal sinus, middle ethmoidal sinus, and posterior ethmoidal sinus. Posterior ethmoidal sinus, and here will be the sphenoidal air sinus will be opening. It's about what you say the sinuses. The infections of this sinuses is known as the sinusitis. So maxillary sinus most commonly involved. It may be infected from the nose or from the caries of the tooth. So whatever you are seeing, this is nothing but the maxillary sinus. See, below is the tooth, and this side is the nasal cavity. So it may be infected by both route, from the oral cavity as well as infections from the oral cavity as well as from the nasal cavity. So antrum puncture can be done by breaking the lateral wall of the inferior meatus. So this is the inferior meatus. By breaking that, we will be reaching and we will be draining the infectus from that. So an opening can be made at the canine fossa to the vestibule of the mouth, deep to the upper lip and all. So that is called as Kulde well look operation. So invasion of the orbit. Next, these are the clinical things when we consider regarding pertaining to the this one. The maxillary sinus arises from the mucosal lining. What is an opening can be made canine fossa, and opening can be made through canine fossa through the carcinoma of the maxillary sinus arises from the mucosal lining. So now we can see that this maxillary sinus is anteriorly superiorly related to the orbit, below related to the oral cavity, and medially related to the nasal cavity. So if any carcinomatous things are there, that will be presenting these symptoms. So if the carcinoma is spreading to the orbit, then the infraorbital nerve will be damaged, and that causes the proptosis and the diplopia and the facial pain and all. Invasion of the floor, bulging, and even ulceration of the palate. If the floor is invaded, then ulceration of the palate. If growth obliterate the canine fossa, then produces the swelling in the face and all. So just will go and backward growth palatine nerve, that will be severe pain in the upper teeth, and growth in the medial direction produces the nasal obstruction and epistaxis and epiphoria, and lateral direction swelling on the face. The frontal sinusitis and ethmoiditis can cause the edema of the lids and infection of sinuses. Pain from the ethmoidal ear sinuses may be referred to the forehead, both supplied the ophthalmic division and trigeminal nerve, and pain from the maxillary sinusitis is referred to the upper teeth and infraorbital skin because of this nerve windup. This is in brief regarding the sinuses. So we have understood the sinuses, their openings, as well as if the surrounding structures are being invading. If it is invading the orbit, it will be causing the diplopia, proptosis, and the facial anesthesia and all. If it is invading the floor, it causes the ulceration of the palate and canine fossa, swelling on the face, and severe in the referred upper tooth, and all these things are there. Next, we will understand regarding the pharynx. So, almost one third of the respiratory system we have understood. Generally, here what we need to understand, summarize in the nasal cavity is its walls, medial wall, lateral wall, roof, floor, and in the lateral wall, the concave meatus and the opening of the ear sinuses, location of the ear sinuses, their infective conditions and all we need to understand. So further, when we see that the pharynx is nothing but the wide muscular tube situated behind the nose, oral cavity, and the larynx. Is it audible? Is okay. Okay, fine. So the pharynx
Sir, you are
is a wide.
visible, sir. The
Yeah,
screen is
sure,
not
sure.
visible.
Screen is not visible. Okay, just a minute. Again, I think I have to share a screen. Is it visible now? Screen? Is screen is visible now?
No, sir, not yet visible.
Not yet visible. Okay. Now? Now visible?
Yes, sir, it is visible. It is visible, sir. It is visible.
Yeah. Fine. So the pharynx is a wide muscular tube behind the nasal cavity, oral cavity, as well as the larynx. So when we see that the in the upper respiratory tract, where the infections are common, the upper part of the pharynx transmits only air, and lower part only food, and the middle part transmits both air and food. So before going to the main topic, main pharynx, so generally what the students do the mistake, that I will first tell, then we'll go in deep further things. uh, Generally The pharynx is divided into nasopharynx, oropharynx, and laryngopharynx. So further, the laryngopharynx will be continuing as a esophagus. But when it comes while writing the exam, they will be taking laryngopharynx to the trachea. So generally, that should the whatever the larynx will be continuing as a trachea. So this is a general mistake the students will be doing. So the the pharynx is a wide muscular tube which is located behind the nasal cavity, oral cavity, as well as larynx. Depending on the area where it is located, depending on that, the pharynx has been named as the nasopharynx, oropharynx, and the laryngopharynx. And upper part transmits only the air. So middle part transmits the air and food. Lower part transmits only food. So laryngopharynx continues as esophagus. The dimensions of the pharynx, it measures about 12 centimeter. Upper part is widest, non-collapsible. Middle part is narrow, and lower part is narrowest part of the gastrointestinal tract except the appendix. So this is about the general consideration of the larynx. When we consider the pharynx, boundaries above, superiorly it is bounded by the skull, and posterior part of the sphenoid and basilar part of the occipital bone, and pharyngeal tubercle. So all these are the superior. So whereas inferiorly, 6 cervical vertebrae, posteriorly, as well as lower border of the cricoid cartilage. This is the inferior boundary of the pharynx. And anteriorly it communicates with this. Posteriorly it is separated from the prevertebral fascia. If you see that, the wall of the pharynx, and here will be the prevertebral fascia. It is separated from the prevertebral fascia. So on each side of the pharynx, that is medial pterygoid plate, pterygomandibular raphe, mandible, tongue, hyoid bone, thyroid cartilage, and all. It communicates with the middle ear cavity. The pharynx related to either side to this structure, styloid process, muscles attached to it, common carotid, internal carotid, external carotid, arteries, and cranial nerves related to them. So first thing, superiorly, the sphenoid bone, basilar part of the occipital bone, inferiorly, the cricoid cartilage and 6th cervical vertebrae, and anteriorly, all the nasal cavity, oral cavity, as well as the larynx. Posteriorly, it is separating from the vertebrae by the prevertebral fascia. On either side, it is related to the medial pterygoid plate and pterygomandibular raphe and mandible, tongue, hyoid bone. So this is mandible, tongue, hyoid bone, all these things. Thyroid cartilage, cricoid cartilage. See, all the things are being related on lateral side. So only in this picture you are not able to see the medial pterygoid as well as the pterygomandibular raphe. So all other thing you can see here. So which you are not seen here, that things are which will be seen in the anterior aspect of the neck. So that is related to the common carotid, internal carotid, external carotid, and arteries of the cranial, and the cranial nerves, carotid arteries and cranial nerves. All these are related to the on either side. The parts of the pharynx that already we have understood. Next. So this is what we have to understand in each pharynx. So first thing, where it is located, we have to understand. Nasopharynx behind the nose, oropharynx behind the oral cavity, and laryngopharynx behind the larynx. So from where to where is the nasopharynx? So base of the skull to the soft palate, base of the skull to the soft palate, up to here is the nasopharynx, and then soft palate to the epiglottis, soft palate to the epiglottis. So from here up to here is the hyoid bone, and here will be the epiglottis. Up to the epiglottis is the oropharynx. Then upper border of the epiglottis, upper border of the epiglottis. So from approximately from here to up to here is the laryngopharynx. This is the larynx and this is the laryngopharynx. So further things that already we have discussed. The nasopharynx, above it is completed by the base of the skull. Below it is communicating with the oropharynx, anteriorly with the nose. So whereas oropharynx above with the nasopharynx, below with the laryngopharynx, anteriorly with the oral cavity. So whereas laryngopharynx above with the oropharynx, below with the esophagus, anteriorly with the larynx. So like this it will be having the communications. So nerve supply, pharyngeal and pterygopalatine ganglion for the nasopharynx, 8th and 9th cranial nerves for the oropharynx, 9th and 10th for the laryngopharynx. So relations, anterior relation of the nasopharynx is the posterior nasal aperture, where the nasal cavity is getting continued with the the pharynx. So oral cavity, anteriorly oropharynx, oral cavity. So laryngopharynx anteriorly is the inlet of the larynx, the posterior surface of the cricoid cartilage and arytenoid cartilage, and posterior surface, body of the sphenoid, base of the occiput, arch of the atlas, and presence of the nasopharyngeal tubercle. Up to the atlas is the nasopharynx. Second to third cervical vertebrae is oropharynx, and fifth and fourth to fifth cervical vertebrae up to sixth is the laryngopharynx. Then lateral wall, nasopharynx, opening of the auditory tube, and is tubal elevation. And in the oropharynx, you can see the palatine tonsil, and here you can see the piriform. So oral nasopharynx is ciliated columnar epithelium, and it is a striated squamous non-keratinized epithelium, and this also striated squamous non-keratinized epithelium. So passage already we have discussed. This passes only air, this passes air and food, and laryngopharynx passes only food. So this is about the division of the pharynx and its relations. This much is more than sufficient for understanding the respiratory functions of the pharynx. So now we know that the upper respiratory tract infections are more common and more frequent. They will be infected fast and even cure also fast because of this Waldear's lymphatic ring. So it will be preventing the further infection to the further part of the respiratory system and all. So what the Waldear's lymphatic ring considered: superiorly nasopharyngeal tonsil, inferior lingual tonsil, on either side is the palatine tonsil, and superolaterally by the tubal tonsil. So these are forms the Waldear's lymphatic ring. The hypertrophy, so this will be mainly functioning to prevent the spread of the infections further in the respiratory tract. While doing so, the lymph nodes will get enlarged. This nasopharyngeal lymph node will get enlarged, and that is called as adenoids. Enlargement of nasopharyngeal lymph nodes is called as adenoids. It may obstruct the posterior nasal aperture and may interfere with the respiration. The hypertrophy of the tubal tonsil. So this tubal tonsil may be enlarged and leading to the middle ear problems. And then the palatine. So next is the these are the other tonsils. The palatine tonsil. It is present in the the palatopharyngeal, between palatopharyngeus as well as the palatoglossal arch. Palatopharyngeus as well as the palatoglossal arch. Between them present is the palatine fossa, tonsillar fossa, Within that present is the palatine tonsil, as it is present near the palate, so it is called as the palatine tonsil. Unless and until the tonsil means it refers to the palatine tonsil. So if it is named, then it refers to the then here we need to understand its external features and surfaces. And more common in this is the tonsillar bed. Tonsillar bed. So just I will go through because many things to cover. So we'll just skip the repetition. Just you understand the external features and their relations. The tonsils have the two surfaces, two borders, and two poles. So this from tonsil from within outwards, from medial to lateral side. This is the tonsillar bed. This is a frequently asked question. The first thing is pharyngobasilar fascia, buccopharyngeal pharyngobasilar fascia, buccopharyngeal fascia, and lower part of the styloglossus here, and lower part of and glossopharyngeal nerve. So all these things will be forming the tonsillar bed from here to here. So pharyngobasilar fascia, buccopharyngeal fascia, constrictor muscles, and lower part of styloglossus. So whatever the structures from here, see that even what is this paratonsillar vein also will be part of the tonsillar bed, pharyngobasilar fascia, constrictor muscle, and buccopharyngeal fascia, styloglossus. All these are the tonsillar bed on which this tonsils will be resting. So just go to as it is a part of the lymphatic organ. Here it will be preventing the infection further. That is only its function in the respiratory. Further details, all these things you can study. So the laryngeal part of the pharynx or the laryngopharynx. So on either side of the nasal cavity, nasopharynx is auditory tube. On either side of the oropharynx, there present is the tonsils. On either side of the laryngopharynx present is the piriform fossa. So laryngeal part of the pharynx, the lower part of the pharynx situated behind the larynx, and it extends from upper part of epiglottis to the low. All these things we have already discussed. This is just repetition. So here you need to, this is about the pharynx. Here you need to understand the different layers of the posterior wall of the pharynx, that is mucosa, submucosa, pharyngobasilar fascia, inferiorly muscular coat, buccopharyngeal fascia, and all we need to understand. Then you have to understand the walls, so the muscles which are forming the pharynx, superior constrictor, middle constrictor, and inferior constrictor. So the structures, then structure passing between the two muscles, the gap, upper concave gap, there passes is the styloid process, auditory tube, levator vellae palatini. All these are going between the gap of this gap. I will show that. So here, this superior, from this gap, all those structures will be passing. Then structure passing through the gap between superior and middle constrictor. Here, see, this is the superior constrictor and this is the middle constrictor. Between this passes is the stylopharyngeus muscle, as well as structure passing between stylopharyngeus muscle and glossopharyngeal nerve and internal laryngeal nerve. All these things, and recurrent laryngeal, all these things will be passing between them. So now here one more structure passing between the pharyngeal muscles. Okay. Then Killian's dehiscence. So this is important between thyropharyngeus and cricopharyngeus. Due to different nerve supply, there will be the outpouching pharyngeal diverticulum, that is called as the Killian's dehiscence. Lower of the single seat of the muscle, not overlapped internally by the superior and middle constrictor, and the level of the vocal folds, upper part of the cricoid lamina is limited inferiorly by the thick cricopharyngeal sphincter known as Killian's dehiscence. The pharyngeal diverticulum are formed outpouching of dehiscence. Such diverticulum normal in the pig. It is not present in the human being. So it is just due to the different nerve supply. So here you can see the nerve supply to the pharynx. So cricopharyngeus is supplied by the recurrent laryngeal nerve, whereas thyropharyngeus is supplied by the pharyngeal plexus. Because of this difference in the nerve plexus, this Killian's dehiscence has been formed. So generally what will happen, whenever the food is advancing to the next part of the digestive system, there the proximal part will be contracting and distal part will be relaxing. When the thyropharyngeus is contracting and the cricopharyngeus fails to relax, then this Killian's dehiscence has been formed. Then you can see the blood supply, deglutition and all. This is not required here. Now just we'll see the auditory tube. Auditory tube. So it is the connection between the pharynx and the between the middle ear cavity, nasopharynx and the middle ear cavity. It is about 4 centimeter long. It is directed downwards, forwards, and medially. It forms an angle of the 45 degree with the sagittal plane, 30 degree with the horizontal plane. In this, the bony part is lateral 1/3 and cartilaginous part is 2/3. All the relations we can go through this. So mainly the clinical importance of this cartilaginous, this auditory tube is, so this will be spreading the infection spread from the nasopharynx to the middle ear cavity. So the next is the larynx. Next, the larynx is the last part of the upper respiratory tract as well as the beginning of the lower, last part of the upper respiratory tract, and it is the inlet for the lower respiratory tract passage. So in otherwise, it is called as the voice box. So it is located in front of 3rd to 6th cervical vertebrae, that is C1 to C4. This is 45 millimeter in males, 36 millimeter in females. And just we can go through the, after seeing the extent and measurement, we have to see about its constitution. It is mainly formed by 3 unpaired and 3 paired cartilages. 3 unpaired cartilages are epiglottis, thyroid cartilage, and cricoid cartilage. And 3 paired cartilages are arytenoid cartilage and corniculate cartilage. So then we know, I'll just explain in, rather than going in deep, I'll just explain few things over here. So thyroid cartilage is V-shaped, where it is formed by joining of the right and left. Each lamina is quadrilateral. They join in the midline, and their posterior border are lying apart from each other, and is having superior cornu and the inferior cornu, where there's laryngeal prominence, Adam's apple, where these 2 laminas are meeting, at that forms the laryngeal prominence or the Adam's apple. So above superior, and it is having the superior border and inferior border. Superior border gives attachment to the thyroid membrane. Below it gives attachment to the conus elasticus and all. So just a minute. Okay. So then the inner aspect are attached to the median glossoepiglottic ligament, thyroepiglottic muscle on each side, vestibular fold on each side, vocal fold on each side, thyroarytenoid. Then cricoid. So this thyroid cartilage is the V-shaped cartilage formed by right and left lamina of the thyroid cartilage, which is joined together anteriorly, wide open posteriorly, having superior and inferior cornu. inferior corno articulates with the cricoid cartilage to form the this cricothyroid joints, that we can understand, and it is giving attachment to all these muscles. The cricoid cartilage. So this is the cricoid cartilage. So it is having the anteriorly the ring and posteriorly the lamina. Anteriorly arch and posterior lamina forms the cricoid cartilage. So on superolateral to the this cricoid cartilage present is the arytenoid cartilage, and this arytenoid cartilage, just a minute. This arytenoid cartilage that articulates to the corniculate as well as cuneiform cartilages. So then the epiglottic cartilage is this leaf-shaped cartilage placed in the anterior wall of the upper part of the larynx. Then attachments of this epiglottis is aryepiglottic fold. Aryepiglottic fold between the arytenoid cartilage, this is the arytenoid cartilage, as well as this is the epiglottic cartilage. Between them is the aryepiglottic fold. Then arytenoid cartilage is also, it is a pyramid shaped present, and then this arytenoid cartilage is having the three processes: vocal process, laterally the muscular process and all, and posterior process. So in the larynx, what we can understand here is it is mainly formed by three paired and three unpaired cartilages, and it is having the joints cricothyroid joint and cricoarytenoid joint, and the laryngeal ligament, extrinsic as well as the intrinsic ligaments we need to understand. The extrinsic ligament, the thyrohyoid membrane, which is between the hyoid as well as the thyroid, hyoepiglottic ligament between the hyoid as well as the epiglottis, hyoepiglottic ligament, and cricotracheal ligament. Cricotracheal ligament. These are all the extrinsic ligaments which are holding these cartilages together. The intrinsic ligament is a broad sheet of the fibroelastic known as elastic membrane of the larynx. This membrane is placed just outside the mucous membrane and interrupted on one side by the sinus of the larynx. So the part of the membrane, so here this part we have to understand here for related to the respiration. The part above the sinus is a quadrate membrane, and below is the conus elasticus. Quadrate membrane extends from the aryepiglottic cartilage to the epiglottis, and lower free border forms the vestibular fold and upper border forms the aryepiglottic fold. See here, this is the sinus, and this is the quadrate membrane, and this is the conus elasticus. Upper border is forming the aryepiglottic this one cartilage. What is this? This is epiglottis, and this is the arytenoid cartilages here, and this is the aryepiglottic membrane, and lower border is forming the the aryepiglottic fold, whereas the lower border is forming the conus elasticus. Lower border is forming the vestibular fold. So whatever we are seeing, this is the vestibular fold, and this is the vocal fold, and between this is the sinus of the larynx. And so now we have, while we are understanding about the extrinsic ligament and intrinsic ligament, we have understood and the sinus of the larynx is present within the intrinsic ligament. It is bounded above by the vestibular fold, below by the vocal fold. And now this sinus of the larynx, the cavity of the larynx, lower border of the cricoid cartilage. Okay, so with the cavity of larynx, two folds of the mucous membrane on each side, upper fold vestibular fold and lower fold vocal fold. The space between the right and left vestibular fold, the space between this Now you can see this is vestibular fold and this is vestibular fold. The space between the two vestibular folds is called as rima vestibulae. The space between the two vocal folds is called as rima glottidis, and the vocal folds is attached anteriorly midline to the thyroid cartilage and posteriorly to the vocal process of the arytenoid cartilage. Rima glottidis is limited posteriorly by the interarytenoid folds. So rima is narrowest part. Okay. So like this, we are understanding the, see here. This is the vestibular fold. This is the vocal fold, and this is the supraglottic part. This is the ventricle, and okay, the sinus morogagni, the mucous membrane. Okay, the anterior. The supraglottis part that is present between the vocal fold is called as sinus of the, okay. The vestibular and vocal fold divide the cavity into three parts of the vestibule, that is supraglottis, vestibule of the larynx, supraglottis, as well as the infraglottis. So the supraglottic part, infraglottic part, and here is the vestibule. Then the anterior surface of the upper surface of upper half of the posterior surface of epiglottis and upper parts of the aryepiglottic folds and the vocal folds are lined by stratified squamous epithelium, and the rest of the laryngeal, the mucous membrane is loosely attached to the cartilages of the larynx except the vocal ligaments and the mucous glands. So the sinus of the larynx or the glottis is the narrowest part of the respiratory system where the foreign bodies are being lodged. So when we see that the foreign body is lodged in the sinus of the larynx, which causes the laryngitis, hoarseness of the voice, and then misuse of the vocal cords, means talking longer time, louder, that causes the teacher's nodule, and fiber optic flexible laryngoscopy. So we can visualize the larynx by the laryngoscopy. That is direct. Indirectly is the microlaryngoscopy. Generally, the foreign body is lodged in the piriform fossa, so that damages the internal laryngeal nerve, and large bodies may block the inlet of the larynx itself, causing the suffocation. So these are the muscles, just to go through it, because this much detail may not be able to cover it up. These are intrinsic muscles, nerve supply for this, and the clinical anatomy. When any foreign object enters the larynx, severe protective coughing is excited to expel the object. Damage to the external laryngeal nerve causes the weakness or phonation due to loss of tightening of effect of the cricothyroid vocal cord. When the both recurrent laryngeal nerve are interrupted, the vocal cords in cadaveric position in between the abduction and adduction phonation is completely lost. When only one recurrent laryngeal nerve is paralyzed, opposite cord compensates. Tumors of the piriform fossa causes the dysphagia. So these are the moments of the, what do you say, this one. So next is the lower respiratory tract. So here in the larynx, what we have to understand is it is mainly found by what do you say, the three paired and three unpaired cartilages, and inlet of the larynx is divided into supraglottis and infraglottic part by the sinus of the larynx, and that we have to understand. Then we have to understand these are the muscles which are keeping these cartilages together, and these are the movements of the intrinsic muscles, and it is supplied by the recurrent laryngeal nerve and the external laryngeal nerve. So actions of these muscles we have to understand. Fine. We'll go to the trachea. Trachea is a non-collapsible forming. Okay, the trachea begins from the larynx, and it ends at the level of, here what we are understanding is it will be ending at the level of T4 has been mentioned, lower border of the T4, and whereas in other books it is mentioned as T5. So generally in the MCQs, this question may be asked. So bifurcation of the trachea at the level of some options will be given. If T4 is given, you should write T4, and if T5 is given, you should write T5. If both are given, then you should write T5. The trachea is measurement of the trachea and all, you can go through it. Then cervical part of the trachea. Trachea is in the cervical part. Trachea begins at the lower border of the cricoid cartilage, and it runs behind the runs downwards and slightly backwards in front of the esophagus, and follows the curvature of the spine, enter the thorax. So anterior relations and the posterior relations of this. On each side, it is related to the thyroid glands. Next is the pleura. The pleura are the coverings of the lungs. So mainly this developing lungs will be invaginating the pleura from its medial side, so that it is having the two layers, outer parietal layer and inner visceral layer. So this pleura is been named on behalf of which part of the lungs it is being covering, that is cervical pleura, costal pleura, diaphragmatic pleura, and the mediastinal pleura. And here one thing we have to understand, that the parietal pleura is 2 ribs lower than that of the visceral pleura in the inferior border. Anterior border and posterior border will be corresponding, whereas the inferior border, that will be 2 line down to the this one. Then pulmonary ligament. The pleura, parietal pleura will be covering the wall of the thorax. Visceral pleura will be covering the intimately covering the complete lungs, and it will be continuing with the pulmonary ligament at the hilum. And the recesses of the pleura we have to understand. So recesses of the pleura, costomediastinal recess. Costomediastinal recess lies anteriorly, means where the pleura is nothing but where the costal pleura and mediastinal pleura is joining, that is a costomediastinal pleura recess. And where this diaphragmatic and costodiaphragmatic, where diaphragmatic and costal, that is costodiaphragmatic pleura. So this recesses, this will be filled during the respiration. These are the blood supply and nerve supply. When we see the clinical anatomy, pleurisy, dry pleurisy, pneumothorax, hemothorax, hydropneumothorax, emphysema, referred pain, and all. So inflammation of the pleura is called as pleuritis. So dry pleurisy is more painful than the other. Pneumothorax, presence of the air in the pleural cavity is the pneumothorax. Presence of the blood in the thorax is hemothorax. And hydropneumothorax and emphysema, these are all the things. So next, lungs. Here the lungs are occupying the major portion of the thoracic cavity. So right lung and the left lung. The right lung is presenting the 3 lobes, left lung is presenting the 2 lobes. So go through this, all the details here. Mainly what we have to understand in the lungs is this site determination, root of the lung. Root of the lung we need to understand here. A minute. The root of the lung. Root of the lung is short, broad pedicle, connects the medial surface of the lung and to the mediastinum. It is formed by the structures which either enter or out of the lung. The root of the lung opposite to the body of 5th and 6th vertebrae. The root of the lung are following structure. Principal bronchus on the left side, and only one bronchus on the left side. On the right side is the epiarterial bronchus and hypoarterial bronchus on the right side, and one pulmonary artery and two pulmonary veins and bronchial arteries, one on the right side, two on the left side, and the bronchial veins. This you have to understand, and this is the difference between the lungs on the right side and the left side, and arrangement of the structures in the root from in the root. By this only we will be able to, because sometimes in the anomalies presence of additional fissures and additional lobes will be there. Just by consider, sometimes the right lung also will be presenting only two lobes, left lung also presenting two lobes. Then you have to do the side determination by seeing the what do you say, the uh, root of the lung as well as the vertebral area in the mediastinal area. Anteriorly is the so mainly the lungs will be having the uh, diaphragmatic surface, costal surface, and mediastinal surface. Mediastinal surface is anteriorly is the cardiac and posteriorly is the vertebral. By considering that, we have to do the side determination. So, so if you see that on the right side there will be the two bronchus. That is the, even there will be variations even in that also. So in all together we have to consider the surfaces, and even the after examining the structures of the hilum of the lungs also we have to consider in this. Epiarterial from above downwards, epiarterial bronchus, pulmonary artery, and hypoarterial bronchus and vein. So generally vein, artery, and bronchus like that. So here on the from on the right side, first comes is the bronchus, then comes is the artery, and then comes is again bronchus, and then comes is the vein. So this is, and on the left side, pulmonary artery and bronchus and inferior pulmonary vein. So this is about relations of this. Lymphatic drainage, the arterial supply. Lymphatic drainage. There are two sets of the lymphatics, both which drain into the bronchopulmonary nodes. The superficial vessels drain into the peripheral tissue, and deep lymphatic drains into the bronchopulmonary, both which drain into the bronchopulmonary lymph nodes. Parasympathetic nerve, mainly the vagus, and sympathetic, second to fifth sympathetic ganglia. So here the trachea is dividing the right and left principal bronchus. That is about just to understand the difference between right and left principal bronchus, and it is having the 10 segmental. So, so first is secondary lobar bronchi, tertiary segmental bronchi, and terminal bronchiole, respiratory bronchiole. And when we see that, these are well defined anatomical, functional, surgical sectors. So relation, this is important while understanding the clinical aspect. Relation of the pulmonary artery. So branches of the pulmonary artery accompany the bronchi. Here what we have to understand, pulmonary artery is bringing the deoxygenated blood for the purification. That will be accompanying the bronchi. Artery lies dorsolateral to the bronchus. Relation of the pulmonary vein. The pulmonary vein do not accompany the bronchi or the pulmonary artery. They run in the intersegmental planes. So if any affected part has to be done, that has to be worked out along the intersegmental, along the pulmonary vein. So there will be the one artery for one segment, but there will be many veins for the one segment. So like that. So these details are not much. Clinical anatomy. Usually the infection of the bronchopulmonary segments remain restricted to it Although tuberculosis and bronchogenic carcinoma may spread from one segment to another, the knowledge of detailed bronchial tree helps considerably, and segmental resection. So here one more thing, Carina hook shaped process projecting the backwards from the lower margin of the lowest tracheal ring and helps to divide the trachea into two primary bronchi. Right bronchus makes a 25-degree angle, which left makes on a 45-degree. The foreign bodies mostly descend into the right bronchus as it is wider, more vertical than the left bronchus. Enlarged lymph nodes. So here, what is the importance of the carina is more sensitive area. When the person is lying on one of the side, like right side or left side, then whatever the infected like sputum and all, that will be coming near to the carina, and by the cough reflex it will be put out. Then the paradoxical respiration. Paradoxical respiration is nothing but the opposite to the normal respiration. So generally what will happen while we are during the respiration, the chest wall will be expanding. Here it will be, what do you say, there will be no expansion. So the ribs are pulled inside during the expiration, inspiration. And what normally ribs will be pulled out, pushed expiration. So if any underlying pathology is there, that this will happen. Then tuberculosis, commonest disease of the lungs which are affecting. So ribs and diaphragm in respiration. When the diaphragm flattens, so mainly these are the now main structure only we are not able to cover up. Just the rib and diaphragm is playing major role in the respiration by slighter movement. The ribs move little and they allow chest to expand. So whereas diaphragm um, relaxes and assumes its dome shape, and then lungs move back, the air from inside enters the outside, which is called as expiration. So diaphragm, when the diaphragm flattens and rib moves, the chest will be enlarged. So when the diaphragm assumes the dome shaped, the chest will be, that will be expiration. In the inspiration, diaphragm becomes flat and ribs will be moving, and the during expiration ribs comes to normal size and diaphragm becomes, what do you say, the flattened, so dome shaped. So here in the discussion, what we are understood is, in the upper respiratory tract we'll be understanding completely the anatomy of the nose, as well as nasal cavity, sinuses, as well as the pharynx and larynx. In the lower respiratory tract we'll be understanding about, what do you say, the trachea, lungs, pleura, ribs. Up to that we'll be understanding. And this ribs and diaphragm are nothing but the supporting structures. As the because of presence of the lymph nodes, as well as the upper respiratory tract is nearer to the openings are nearer to the upper respiratory tract, it gets easily infected, and as well as it gets easily cured also. So whereas in the lower respiratory tract infection, the infection is deep situated, so it is secondary to the upper respiratory tract infections, and they are difficult to treat because of they have the whatever the infection has to move, it takes longer time, sputum and to longer distance to travel. So this is about the thing. If anything, I will conclude here. uh, if any things are there, you can ask.
Thank you, sir. Thank you
Welcome.
for the elaborative session on respiratory system, sir. For taking for dealing with complete details of the respiratory system, sir, which run for almost 2 hours. Thank you again, sir, for accepting the request and despite your busy schedule for taking up the session. Actually, um, you agreed for twice. Your session was readjusted, and you also agreed for that, sir. So we are very glad to have you on the session today, sir. And on behalf of my whole team at Jignasa, I would like to extend our warmest gratitude to you, sir, for
Thank
hosting
you.
this session, and we would like to collaborate with you in future also, sir. We
Yeah,
have got.
because hmm, yes,
Yes, sir. We have got certain questions, sir.
yeah,
I will be forwarding it to you on that on WhatsApp, sir, because
okay,
we have
hmm,
another session lined up today.
okay,
We are supposed to start by 7:45, but we will start it by 8 o'clock.
okay.
Um, we are sorry for that, sir, because
It's okay. No issues, no issues. Hmm,
yes, sir. I
thank you.
will be forwarding you those questions, sir. And
Yeah,
on behalf of my whole team, this was the first of a kind of initiative that is taken up by the students for our juniors, sir. We wanted to do something for them, and
yeah, sure.
thank you for being a part of this beautiful journey and work, sir. And we are
Pleasure.
really grateful to you, and we look forward to meet you on one day and to plan for some programs and to make anatomy more fun in a way that easily understood by students, sir.
Yeah,
Thanks
thank you.
for joining us today, sir. We are
Thank you.
really
Thank you.
grateful to you.
Thank you. Thank you.
Thank you, sir. Now I request your session permission to end the session, sir.
Yeah, thank you. Thank you.
Thank you, sir.